All right. Our next speaker is Dr. David Madoff. He's the Chief of Interventional Radiology and a professor at New York Presbyterian Weill Cornell Medical Center in New York City. And he's been in practice for over 15 years. So welcome, Dr. Madoff.
Okay, thanks. I guess before we get started, I should make one little correction. And it's actually pronounced Madoff. It's first question is, am I a relation? And I will not admit to anything. So anyway, I'd like to thank the Waymans for inviting me and the board of directors. As you all have heard, there's a lot of interest in liver-directed therapy, and it's one of those things where even though it's the end of the day, and I appreciate you all for staying, I think that a lot of patients with neuroendocrine tumors eventually are going to have liver disease at some point, and I think that it's important for everyone to at least be on the same page and understand what it is that we're talking about. Just to briefly go over this again, as you're all aware, there's been a lot of treatments for neuroendocrine over the years. Octreotide has definitely changed the playing field, and ultimately it leads to good symptom control. However, when patients do have distant disease, the primary mortality is actually related to organ failure, so local control really is the key. If we look at this study from 2008, we can see that the poorest prognostic variable, and Dr. Metz, I believe, mentioned that earlier this morning, is in the liver. So it's very important to control the disease that is within the liver, because that's where ultimately mortality is based. Now, I just wanted to show you a couple of slides. These are three completely different patients that I treated. In this slide, you can see that the patients all had very localized disease. So here we see a very small tumor here. This is actually a cyst, but these patients all had neuroendocrine tumor, very small tumor in the right posterior liver, another small tumor carcinoid in the left liver, and a couple of other tumors in this patient in the right liver. Interestingly, each of these three patients got a completely different treatment. Now looking at patients with diffuse disease, here we see three patients that also had different treatments. This patient with neuroendocrine had a chemoembolization, this patient here had a bland embolization, and this patient here had what we call a radioembolization. So ultimately, we have all these different modalities at our disposal, and how do we decide which patient gets what treatment? So as we know, neuroendocrine tumors are relatively slow growing compared to other tumors. However, it is important to decrease the tumor burden because this ultimately facilitates symptom control. Now, you can have a very small tumor, as we discussed earlier, and have a very major symptoms, and you also can have a very large tumor burden and ultimately be asymptomatic. But the thought is that if you can get to treat the tumors earlier is pretty much considered better than treating them later. Now, how do we determine which patients would, or when a patient should get an image-guided intervention? We look at patients that have symptoms despite being on medical therapy, and we find that we can get about 90% or more patients to have benefit from these therapies. And this symptom relief with simple treatments like what we have can last up to 2 years, and then you can ultimately give the treatments again. We look for mild deterioration of liver function tests. And when we say mild, we really mean mild, because ultimately if you have severe liver dysfunction, the procedures or treatments that we will offer will not be able to be undertaken, because we could actually make the liver function worse. We look at bulk-related symptoms, and we also look at trying to get patients to hepatic resection, whether that's reducing bulk or increasing their performance status to get them to resection. When we try to decide which therapy a patient should get, we have to look at disease location and extent. Now, normally when you're talking about ablative therapies, you're really talking about low-volume disease, patients that have less than 3 or less tumors, and each being less than 3 centimeters. Now, Dr. Ioniti this morning had shown cases of 50 tumors that were treated. Now, that would be considered pretty much quite aggressive, and I'm not sure that many institutions would do that, but I'm sure that the results are good. But just be aware that local ablative therapies are usually for more lower volume disease. Regional treatments, what we call treating the entire liver, is more for diffuse disease. He said earlier that bilobar disease, basically what that means is you have disease in the right side of the liver and also in the left side of the liver, and also in patients that have tumors in difficult locations for surgery. We also look at the tumor histology, and I'll get into that in a little while, how we treat patients with carcinoid a little differently than patients with pancreatic islet cell. We look at procedural considerations, which include outpatient versus inpatient, general anesthesia versus moderate sedation. And we also, we discuss with the patient what their preferences is, because it's not just the doctor that makes the decisions, it's also the patients and their families and that. Now, when we talk about local regional treatments for liver cancer, interestingly, when I first got to Cornell 4 years ago, we used to discuss local regional therapy, and the surgeon at tumor board would always get upset because he would say that surgery itself is local regional. So we always now put local regional as surgery as part of it. We look at ablative techniques and transarterial therapies, and I'll get into that in a minute. Now, what are the barriers to liver resection? Basically, only 10 to 15% of patients are eligible for resection that do have liver disease. We have to look at the number, size, and the location of the tumors. We have to look at the size of the liver after surgery, okay, and that's what's called the future liver remnant. So when you're trying to plan the surgery, you have to see how much liver will remain afterwards, because patients that have too small a liver, that means that they have to take out a large amount of liver to get all the tumors out. A lot of patients that have too little liver left will actually go into liver failure after surgery, and they have a very bumpy postoperative course. We also understand that patients with extrahepatic disease may not do as well, and we also look at patients that how their tolerance is to surgery. So if a lot of patients have major comorbidities, they would preclude them from having surgery in the first place. Now, this is just a patient, 71-year-old with a single carcinoid tumor. This is one I showed a little earlier. This is a small carcinoid in the left liver, abutting the left and middle hepatic veins, and also has some evidence of biliary obstruction, which are these vessels right here. We were asked to embolize the patient to shrink the tumor, and the idea was that the patient was very emaciated, and the surgeon did not think that she would be able to tolerate a very large resection. And this patient was planned to have what's called an extended left hepatectomy, where most of the entire left plus half of the right liver is actually removed. So we did the embolization procedure. We see that there's a slight shrinkage of the tumor. The patient was able to gain 30 pounds over the next couple of months, and then the patient did have successful resection. And this is what the liver looks like after the surgery. So you see this whole area here was at one point liver, and now it's all filled in by bowel. This is another patient we treated at MD Anderson, a 55-year-old with multiple metastatic carcinoid tumors. There was no tumors found in the left lateral liver, which is this area here. An altriotide scan showed no extrahepatic disease. So the proposed treatment in this patient is an extended right hepatectomy. What that means is that this whole part of the liver here is actually removed, and you're only living off of this small area, okay? So in this patient, we measured their volumetry. We do CT volumetry, which basically means that we're able to see the size of the remnant liver before surgery. And this patient had, if they had the surgery now, would have had only 15% of their liver left, which means that they would have had 85% of their liver removed at one time, okay? So what we can do, and this is something that we were very active in, the research and the clinical aspects at MD Anderson, we're doing a procedure called preoperative portal vein embolization. What this procedure does is it redirects all of the blood flow from the entire liver, from the portal vein, to just the liver remnants. And you can see here that we block up all the flow to the liver that's going to be removed, force all the portal blood flow, which has all the nutrients that cause the liver to grow, to the left lateral liver, or what we call the future liver remnant. And we're able to actually get this liver to grow before surgery. So ultimately, the idea is not necessarily that you're not treating the tumors, but because the tumors are supplied by the hepatic artery, but you are trying to get the liver to grow before surgery, and ultimately achieve similar survival rates to surgical patients that didn't require the portal vein embolization in the first place, because they already had enough liver that they didn't need the portal vein embolization. So this is just what the liver looked like. Go back one. The liver looked like before portal vein embolization, and 4 weeks after the portal vein embolization, we see that the left lateral liver is now huge. So this patient grew from 15% to 24%, and based on a lot of the work that we had done at MD Anderson, we knew that 20% was the cutoff. So this patient now had more than 20% and was able to get their surgery, which they had, and you can see that the most of the liver was removed, and this is only the left lateral liver, and this patient did very well after the surgery and ultimately lived 4 years after the resection. Now, what I want to do is go into a lot of the interventional procedures that we do. Okay, I've already discussed a few. We talked about embolization. We've already heard today about ablation. One of the issues that I have, and it turns out that our field is very specialized. And I can tell you that my parents don't even know what I do for a living. Okay. Interestingly, you would be surprised that a lot of doctors also don't know what I do for a living. So if you read a lot of the discharge summaries and a lot of the reports, you'd see that the reports are actually quite incorrect. Okay, so for example, a lot of the terminology is used interchangeably. So for example, TACE, which is chemoembolization, is often used instead of bland embolization or transarterial embolization. So there's no chemo involved. So the idea is that it's very, very different therapy. The same thing for ablative therapies. RFA is the longest and oldest type procedure done for ablation, although I guess ethanol ablation is too. But microwave sometimes is used interchangeably. And if we talk about radioembolization, a lot of times it'll be said that it's just considered radiation therapy. So knowing what you actually had from a patient perspective is extremely important because this has major implications on accurate medical record keeping, so you know what was done, as well as the billing for the insurance company, which actually I don't get into one iota. As far as locally ablative therapies, there's a numerous number that are available. I actually don't want to get into all the detail about it, and Dr. Ianniti said that I probably would, but I think from a patient perspective, I think that ablation is ablation if you're talking about ablation in the liver. Now, there are certain circumstances where you may want to use irreversible electroporation or microwave instead of other types of procedures, but I don't think from looking at the survival curves that as long as the tumor is ablated, I think that should be fine. As far as the goals of ablation, the goal is obviously to eradicate all the viable malignant cells and at the same time spare normal surrounding tissues. So what that means is that a patient that has a big resection, they're taking out a lot of the normal liver in addition to the tumor. So the idea here is that if you can ablate and still get the same survival and also get less complications, that's obviously advantageous. Ultimately, one of the goals is to treat tumors with unfavorable location or have difficult patterns of distribution, which make the surgery challenging. And again, if patients have multiple comorbidities, and as I said earlier, it's most often used in patients with low volume disease. RFA, radiofrequency ablation, is has the largest amount of published literature, and it's based on electric current via an electrode to the tumor. And there's actually resistive heating, which means that you get a lot of the tumor kill right up to the edge of the needle. And then as long as you can keep the temperature hot, you can actually get killing beyond that area. So that's called resistive heating. Now, over the years, in order to improve the size of the liver ablation, a lot of different devices have come out. So there's all these different shapes that that are shown here that are trying to help with it. This is just a case, a very small tumor in the right lobe of the liver. Here we see the ablation zone 1 month after the ablation. And this tract here is important because that actually is a cautery device. So you actually ablate the lesion, cauterize the tract on the way out so you don't bleed or see tumor. And then this is the scan 3 years later. Microwave is a newer technology. There's a lot less data on it. However, you can get higher tissue temperatures, which allow for better ablation efficacy. And because of that, you can get larger ablations in a shorter amount of time. I think Dr. Ianniti may have mentioned briefly about what's called the heat sink effect. Basically, tumors that are very close to large blood vessels will sump the heat away from the tumor and therefore cool the side of the tumor that's in very adjacent to the large vessel. And that's where recurrences happen or untreated areas of tumor. So microwave, as opposed to RF, is much better at trying to reduce the heat sink. And also there's a lot of studies now that are coming out that show that there's similar local control, survival, and complication rates using microwave rather than RFA. This is just a case very similar to the one I did with RFA. Again, very small tumor here. This is actually a cyst. Very small tumor in the right posterior liver. Ultrasound shows the tumor here. We put the needle into the tumor. We actually used 2 needles, but this is with CT. Immediately after the procedure, we did a contrast-enhanced CT scan where you see the ablation zone here, and then 18 months later, the tumor is completely gone. Now, when you do ablation, you're not going to see, when you have what's called a complete response, you're not going to see in ablation nothing there. Like, you're still going to always be some kind of defect showing that something was done. Unlike chemotherapy, where it may show a complete response, shows that sometimes the tumor is completely gone. This will not happen with ablation. As far as cryoablation goes, there's some images here that are missing, which is interesting. But the idea here is that instead of heating the tumors, you actually cool the tumors to about 190 degrees Celsius. And this works to cause direct cellular injury, vascular injury, and immunologic injury. Now, there's advantages and disadvantages of cryoablation to heat ablation. I just want to go over that briefly because Dr. Ionity seemed to have some very vast experience back in the 1990s with this, but it's actually fallen out of favor when looking at treating liver tumors. It is very useful in the lung, in bone, and in kidneys, but I personally would not recommend doing that in the liver. And the reasons are that despite the fact that you get the advantage of being able to cause very large ablation zones, and ice is a natural anesthetic, so you can probably do this under moderate sedation as opposed to general anesthesia, which I always use for heat ablation. You also can see the ice ball within the liver. So you see this right here, and you can actually reproduce it very nicely because you have algorithms which show what the ice ball should look like. The disadvantages, however, are that because you're placing many more needles, the procedure times can take longer. You actually have an increased bleeding risk because you're not cauterizing the tract on the way out, because when the ice ball melts, you actually can get bleeding if you injured any arteries. And there's also an entity called cryoshock, which has to do with tumor lysis syndrome, where you're actually getting all of the chemicals that are in the tumor circulating around the body. And that causes, for some reason, in cryo and not in other heat ablation, types of heat ablation, you actually get something called shock. You actually can go into shock from it. So from our standpoint, in the interventional radiology community, it's very unusual that you would actually use cryotherapy for liver tumors. As far as transarterial therapies, basically these are catheter-based treatments for therapy where we use embolic agents or therapeutics intra-arterially directed to target tumors. Okay, catheters, for those of you that don't know, are these like tubes that look like kind of spaghetti that have a lumen within it. And because of the technology has advanced so far over the past many years, we can actually get very, very, very small catheter diameters all the way out to the periphery of the liver. So the idea here is that you're able to get the catheter directly to treat the tumor and exploit the observation, as I mentioned earlier, that the hepatic artery is where the tumors receive their blood supply. Okay? And knowing that 75% of the blood supply or 80% of the blood supply comes from the portal vein, you actually don't have to really worry about infarcting any part of the liver. So ultimately, we can preserve normal tissue, okay, and we can selectively and locally deliver these therapies to the tumor bed while sparing normal surrounding tissue. So this just shows an example of an embolization where you have the catheter tip here, and these little balls or little dots here represent particles, okay, which actually are embolics. if you all think about what a pulmonary embolism is, it's basically a blood clot that goes to the lungs, gets stuck there, and stops the blood from going distal to it. It's the same thing. Embolization. It's not an obvious word to a patient. Maybe it's a little more obvious to a physician. But being that this is a patient education conference, I think it's important to really get the understanding of the fact that we're taking these little particles and we're plugging up the tumor blood supply, and then depending on what we decide, could either use radiation, chemo, or not, or use just the particles themselves. So there's really two classifications that we're currently using in interventional radiology. We have the embolotherapy or chemotherapy-based procedures, and we also have the radiation-based procedures. And we'll get into each one of these in a lot more detail. Just so you're aware, patients that do come to us for liver-directed therapy, we need to prophylax them for example, carcinoid syndrome. So all these patients will get pre-treated with octreotide, as well as before the procedure and during the procedure. And then ultimately, and also after the procedure, because a lot of the things that we do actually take time for them to necrose the tumor, kill the tumor, and these molecules are getting them into the bloodstream at a later time. So as far as transarterial embolization, this is bland embolization. Okay, this is TAE. TACE is not this. So this is considered embolization without chemotherapy. Okay, and we use these different kinds of beads. Some of these, like the old kind, which is polyvinyl alcohol, are these jagged little particles, and we can get them of different sizes depending on how far deep into the arterial bed you want to get. The goal here is to cause ischemia of the tumor. Okay, and ultimately, because of the ischemia, similar to having a heart attack, for example, we can actually cause necrosis of the tumor just by the embolization procedure without the chemotherapy. So this is a patient that we were asked to treat based on the fact that he had pain in the anterior right part of the liver, and we can see this tumor here. And this tumor actually got a little larger and started to bow out the capsule of the liver a little bit. So we thought that if we could actually shrink the tumor, that the patient's pain would go away. So we did a procedure. This is the angiogram. I'm going to go into a little more detail later about the different arteries and things like that. But suffice to say that this is the arterial supply to the liver. This is the liver right here. And this is actually what's called a digital subtraction angiogram, which means that you are only seeing the contrast. The technology that we have today could actually subtract out all the bones and all the gas, and ultimately we're seeing just where the contrast goes, and this is the hepatic artery. And ultimately we're able to catheterize the artery going to that area. Now this was not a very vascular tumor, but we were able to actually get the material in there. So this just shows a cast on the digital subtraction angiogram of the particles being stuck in the artery. And when we saw the patient back about a month later, you can see that it is now this defect where we know that we treated the patient. And we see it here and here. So this was the actual arterial area that we treated. This is another patient that had carcinoid. This patient was suffering from flushing and diarrhea with an increased chromogranin A, despite long-acting standard therapy. And ultimately, you see the tumors here. This is on the initial pre-bland embolization scan. And after 4 treatments, you can see that the tumor is now partially necrotic with holes in the middle and much, much smaller. So the patient's symptoms greatly improved after the embolization procedure. So as far as going over the advantages and disadvantages of bland embolization, basically, the advantages are that the materials are readily available. So what that means is that if you were to come into my office for a consult, I could actually say that we can get this done tomorrow. Okay, there's really no need to wait because we have all the materials available. We also can get very selective into the hepatic arterial circulation. We can repeat this over and over and over again until the arteries get kind of, I don't know if the word fried is the right word, but they start getting attenuated. So patients can actually have this for many, many years without any issues to the arteries. Because we're not using chemotherapy, there's no systemic chemotherapy effect. Insurance usually covers this pretty quickly. and the patients usually get moderate sedation for this unless there's some underlying comorbidity. As far as the disadvantages, because your goal is to necrose the tumor right away, it can be quite painful. So we would potentially hospitalize the patient, at least for an overnight admission. Due to the ischemic effect and necrosis, you also may have a rapid release of the hormones. So you could actually go into carcinoid crisis during the procedure. And if there is extensive disease burden, as in this case where there's multiple tumors all throughout the liver, this may require multiple sessions to treat the liver just one time. As far as chemoembolization, we now have two types of chemoembolization. We have conventional chemoembolization and we have what's called DEB-TACE. Conventional chemoembolization is similar to classic Coke, okay, where they thought that they had a better option, and then afterwards they figured out that maybe it wasn't the better option, so now people are considering this conventional or old-fashioned chemoembolization. What this is a mixture of a lot of the different agents that we talked about already with the bland embolization, and for a lot of primary liver cancer such as hepatocellular carcinoma, we actually use an agent called ethiodol, which is an oily-based mixture, and we then mix it with the chemotherapy. Okay, the issue here is that it's a non-standardized therapy. So some places you can do lobar, some places you get selective. There's this debate on whether you should go completely occlusive versus non-occlusive, which means that you're completely plugging up the blood supply. There's some groups that believe that you should go non-occlusive because if you completely occlude the artery, you get an increase of vascular endothelial growth factor, which then may cause the tumors to actually grow. There's also various chemotherapy regimens, whether it's the drug or whether it's single drug versus combination drug. And again, there's multiple embolic agents that we've already discussed. So there's a lot of non-standardization of conventional chemoembolization. And this is just a patient that we treated a while back, which was a 66-year-old patient with islet cell tumor. This patient has tumor throughout the liver, huge tumor burden. And in this particular patient at this time, we had only treated the left side. So this shows that the tumors in the left have actually gone down or decreased in size and vascularity considerably, while the tumors in the right side have not. So you have to really look at the liver's hepatic reserve to make sure you can even do a lot of these procedures, because if there's too much tumor burden, you actually have increased number of complications. So the advantages and disadvantages are very similar to the bland embolization, with the added lack of benefit, so to speak, of chemotherapy toxicity, which then may cause injury to the tumor arterial blood supply, and you can ultimately use this procedure less and less than with the bland embolization. And also there is some data out there that shows that because of the way that the procedure is done, you can actually get some systemic chemotherapy effects. So as looking at survival, these are a lot of papers that were published from 2005 or 2003 to 2007, showing very similar survivals based on the different types of procedures and the different studies. However, at MD Anderson, when I was there, we looked at the data, trying to evaluate whether chemotherapy added anything to the treatment of neuroendocrine tumors. Okay, now we already heard from the Waymans that it does actually, in certain situations, you may want to give chemotherapy. However, when we looked at patients that underwent embolization and chemoembolization for both carcinoid and islet cell, we found that the response rates were much better for carcinoid without chemotherapy, which was the opposite for islet cell. However, when we looked at the overall survival, there was absolutely no statistically significant difference. So we looked at it and said, well, these patients actually have better response rates and have the same overall survival. So what does chemotherapy actually add? The opposite is true for islet cell. So the practice that we had at MD Anderson, and we're still using at my other job, is bland embolization for carcinoid and chemoembolization for islet cell. And this is a study at the University of Pennsylvania, which shows opposite effects, where they feel that the chemoembolization actually is better. So depending on what institution you go to will also depend on what kind of therapy you get. The next one is called drug-eluting beads, or DEB-TACE. The idea here is that with conventional TACE, as I already mentioned, the retention of the chemotherapy is very variable, and ultimately you get decreased efficacy of tumor kill. You get rapid washout of the chemo, so you get a higher systemic toxicity. Whereas the idea of using drug-eluting beads is that you can then predict the retention and the washout of the. So ultimately, here we see that over time, this is the conventional TACE. You see a much higher serum level of chemotherapy than with the drug-eluting beads. So some people would believe that it's actually a better way of doing things to reduce systemic toxicity, and ultimately, because of the way it's done from a technical standpoint, you can actually standardize the technique. And this just shows what the goal is. Okay, so chemotherapy, you can see that the whole body is basically affected by the chemotherapy, whereas when you give conventional TACE, most of the material is in the liver, but you still have some systemic toxicity, whereas the drug-eluting beads, the goal is actually to only be within the liver and have no systemic toxicity at all. And this is just a case of neuroendocrine tumor. This is from a paper that was published back in 2008. Here we see large tumor in the right lobe. After the DEB TACE, it got much smaller and partially, mostly necrotic. This slide just shows the time course. So basically the idea here is that DEB TACE has a slower time course than with the chemoembolization and the bland embolization. However, that may or may not be a good thing, because we have seen patients come back to the emergency room after a week of DEB TACE where they haven't come back with the bland or traditional chemoembolization. So we can see that you can get much more delayed effects, up to even 2 weeks with DEB TACE. What I wanted to show with this slide is that here we see, this is a tumor. Now this is actually a colorectal tumor, okay, this area here. Now you see that there's multiple small tumors, okay? After the DEB TACE, you can see that there's now a large area of necrosis, which wasn't necessarily just the tumor, but also encapsulated a lot of the underlying normal liver. And the reason for this is that the chemotherapy leaches out of the beads very slowly, and ultimately it has a much longer contact time with the liver, and ultimately will then give necrosis to the normal tissue, which is not advantageous. So in the setting of no cirrhosis, I suggest, and others, suggest using caution with DEB TACE in the non-cirrhotic liver. So the advantages or disadvantages here, advantages are pretty much the same, except that there's supposed to be less chemotherapy side effects. However, as I had mentioned just now, you do get delayed side effects, and the other question is whether or not the chemotherapy that we're using within the drug-eluting beads is actually appropriate for this kind of tumor anyway. Okay, so what usually is used for primary liver cancer is doxorubicin, okay? And what's normally used for DEB TACE in colorectal mets is irinotecan. So what drug do you use for neuroendocrine? And the other issue would be, you have to have these beads soak up the chemotherapy. What drug do you use that would actually be able to be used in the bead? Lastly, just wanted to talk about radioembolization. You heard about this a little bit. This is a procedure that's not supposed to be embolic. It's supposed to kill the tumors. And as was mentioned earlier, there's a very small penetration. So despite the fact that we're always telling patients that you need to stay away from loved ones for 3 feet for 3 days, it's really, I don't think there's any consequence to it. Also, the half-life of this material is 64 hours, so the treatment's going on for a long period of time. Currently, there are 2 commercially available devices. There's TheraSphere and SurSphere. TheraSphere, as far as indications by the FDA, is a humanitarian device exemption of HCC, or hepatocellular carcinoma, whereas the indication for SurSpheres is colorectal cancer. Okay. Now, as a physician, you can use either one you want. However, if you use TheraSphere, you actually have to have it under an IRB. So every time a patient comes in that wants TheraSphere as opposed to SurSphere, SurSphere you can just do, whereas TheraSphere you actually have to get an additional consent form. There's differences in the actual composition of the material, the number of spheres, and what's interesting is that the number of spheres is much lower for TheraSphere. However, each particle that you're using is actually much, much hotter. So there's a lot of differences in the different embolics that we use. As far as therapy planning, there's differences also. The Y90 actually requires a therapy planning arteriogram before you actually give the treatment. And I'll get into that whole business in a second, whereas that's not necessary for the other embolization procedures. It's also, most of the time, the radioembolization is done as an outpatient, where traditionally chemoembolization and bland embolization have been used as inpatient, largely for pain control, but in the setting of neuroendocrine, you may want to keep patients just for hormonal issues. And then there's also endpoint uniformity. So I had mentioned that a lot of the embolic procedures are very variable. Okay? The Y90s, actually, you have a dose, it's calculated, and we're actually able to see the endpoint. This is just a mapping procedure. So basically, a patient comes in on day 1, and they get a mapping. The mapping part is not the treatment. So if you were to have bilobar disease, that would mean that you would actually have 3 separate procedures. The mapping, the right lobe treatment, and the left lobe treatment. Okay? We do this for a number of reasons. First, we want to make sure that the anatomy is favorable, to make sure that we don't have any complications. And then oops, oh, that's good. So I was going to actually test you all on this to see if you knew all the anatomy of the liver, but it's important because the interventional radiologists know this anatomy very, very well. And it's very technically challenging. So in this particular patient, for example, just to go over a little bit of anatomy, this is the celiac axis. This is the common hepatic artery. This is the gastroduodenal artery, which if you infuse particles down into the GDA, you can get a lot of ulcers. So it's very important to know where you are. This is the splenic artery. This is the left gastric artery right here, and that's important. This is the proper hepatic artery, which then divides into the right and into the left hepatic artery. So we inject both arteries to make sure that, that everything is going into the liver and that there's no issues. So one of the reasons why you inject a technetium is you want to make sure that there's no major shunting. There's always going to be a little bit of shunting in the liver because the artery and the portal vein and the hepatic veins are all connected. Okay? But if you have too much shunting, meaning more than 20%, you would actually not get the treatment. Okay, so this, again, is a simulation of where the Y90 will go for the subsequent 2 procedures. So in this case, you can see that all the material goes to the liver, very, very little, albeit some, goes to the lungs. This would be an exclusion case. This is a patient that you injected the technetium in. You can see here that the material within the liver. However, the lungs are lighting up really, really bright here. Ultimately, the lungs can only tolerate a certain amount of dose over the course of one's life. So this would actually limit, A, whether you can have this one procedure at all, but it also limits how many procedures of this type you can have in the future. So anyone that has greater than 20% shunt to the lungs would actually be considered at least a relative contraindication to the procedure. There's always ways to shut the shunts down if you really wanted to do this, but ultimately, over time, it's really important not to get radiation peritonitis, pneumonitis. This is another issue. You want to make sure that there's a correctable, if there is any GI uptake, which this is the liver, and here we see a little bit of material in the stomach. Okay, you want to make sure that you can actually treat this and correct any anomaly. So if you see this, it's very important for the interventional radiologist to, at least if you order the dose, be looking for this finding. Ultimately, the ulcerations that are induced by radiation are very different than the ulcerations that are induced normally. So this is not a mucosal injury. This is a vascular injury that's coming from the other direction. So when you talk about the mucosa, you're talking about the lumen. So if you had a gastric reflux, for example, that would be a problem with the lining of the bowel, whereas these are much, much worse and much more difficult to treat. So it's very important that you know what you're doing. We also look at the stomach. Here we see that there's a small artery coming off of the left hepatic artery, right here, and ultimately we can do an angiogram of the right gastric artery and ultimately coil it, so that way nothing goes to the stomach. This is just the setup of the device, not really that important here, just to show that the dose here is very, very small, and it's a very complicated system. And the dose is actually in this lead area here, so not everyone here is getting radiated. And this just shows the mapping of the exposures, where most of the material is within the liver, less of it is in the tumor, less of it is in the liver, and even less of it should be within the stomach and in the kidneys. This is just an example of a treatment before and 26 months after 190. You can see a dramatic reduction in size of the liver tumors. So this is just a case that I treated while at Cornell. This is a 53-year-old patient with pancreatic neuroendocrine tumor and liver mets. Here we see the large pancreatic mass, multiple tumors throughout all the lobes of the liver. This is the celiac arteriogram. All of these balls here are all tumors, okay, big ones. We do the mapping procedure. So again, I must stress that on the day of the mapping, it's the first procedure, but it's not the actual treatment. So even though there is radioactivity being given to the patient, it is not a radiation dose, okay, a therapeutic dose. So we end up doing angiograms of the right liver here. You can see all the little balls are all tumors. And then we do the left hepatic arteriogram, and again we see all these balls, which are tumors. And then we really want to see, we know what the gastric duodenal artery is, it's very easy, but finding the right gastric artery can be sometimes very problematic. And that again would be an issue with trying to prevent stomach ulcers. So in this case, we actually weren't able to see the right gastric artery anywhere. So what we needed to do was do a left gastric arteriogram. I said that it comes off early on the celiac axis. We see the catheter up here, and we do an injection, and we can follow this line right here, and even more so delayed right here. We can see the right gastric artery. Now what's interesting is that if you inject hard enough, you can actually see filling of the celiac axis and the hepatic artery. So the goal here, knowing that you're going to treat the hepatic artery, you want to get all the way out and coil as close or embolize as close to the origin as possible from where your treatment's going to be. So this just shows the microcatheter right here doing another arteriogram. We were able to get the catheter all the way out to where we said before that we would want to place our embolic agents or coils, the little metallic devices to plug up the arterial supply. And then here you can see there's no flow beyond the coil, so we're actually now protected. We then went back, did a technetium to the right side, and then we did technetium a little later to the left side. And this was the SPECT scan, where we can see that there's uptake in both the left and the right liver. The right liver is probably not seen as well for a couple of reasons. One is that the right liver is much larger than the left, so the dose is actually spread out much more. And it's also because if you do the right side first, a lot of degradation happens with the technetium, with the macrogated albumin. So a lot of this may have already been broken down. This just shows where the material went, and it shows that there's no uptake actually in the stomach or in the bowel. And then here we see that there's very little uptake in the lungs. The patient had a shunt of 14%, and now is a candidate for the radioembolization. Again, we see that there's multiple tumors. This is now we have the day of the right treatment. Second procedure, and this is the first treatment. Again, this is all these balls are tumor. We did the injection of the right on day 1, and we're now able to see after the procedure, we do what's called a Bremsstrahl lung scan, which shows us where all the radioactivity went, and it all went to the right lobe. We then brought the patient back a month later, so this is the third procedure, second treatment. And here again, we see the in the liver all of the tumors where we actually treated. And then this is the patient about a year later with what we would consider stable disease. So the patient did very well 1 year after therapy, just note a little bit of fluid around the liver. These are some results that were published in the American Journal of Clinical Oncology. 148 patients, a total of 185 treatments with a median survival of 70 months. This just shows that the toxicity is very low. In 2/3 of the patients, there was no toxicity, whereas in the imaging response, we can see that there was stable disease or at least a partial response in over 80 patients. And this just shows, this is a study that was done from MD Anderson, which shows that even despite the fact that you may have had a previous transarterial therapy, that radioembolization could be done still after other therapies. Because originally, years ago, it was thought that if you do one, you can't have the other. But that is not really true. So the disadvantages, actually the advantages are that you can have this as usually as an outpatient procedure. And again, by treating it in this way, not causing necrosis, you get a slower release of the hormone, so the hypertensive crisis is much less likely. However, the disadvantage is that materials are not readily available. They actually come from either Canada or Australia, and there's the pre-authorization process for the insurance actually takes more time. So, the day you come to my office, unlike the other patients, other treatments, it sometimes takes at least a week or two to just get authorization for you to go ahead with the therapy. Again, it requires an additional procedure, and there's also a limited number of times you can get this treatment because, as I will show you, it can ultimately cause liver damage and possibly cirrhosis in particular patients. So if you're a young patient, for example, 50 years old, that has a long life expectancy with carcinoid, for example, radioembolization may not be the way you want to go. Just to show you a couple, now these are all in your handouts, so I'm not going to go into too much detail, but these are just the short-term adverse events of embolization procedures. I would say that the mortality is actually probably lower than this. This is a study that was done with HCC in patients with cirrhosis, so there's a lot more to it than that. And as far as long-term effects of chemoembolization, you can see that there's still, at least with conventional TACE, you still get a lot of high-grade toxicities from traditional chemoembolization. This is just an ulcer in the bowel, shown here. Patients also can get what's called radiation-induced liver disease, or radioembolization-induced liver disease, where patients can ultimately get jaundice and ascites, and this usually occurs about 4 to 8 weeks after the radioembolization. The potential causes are basically when physicians do whole liver treatments. That means instead of breaking it up into the right and the left, they do it all at one time. And you also have patients that have had numerous chemotherapies, so their livers are already kind of shot. Lastly, as far as adverse events, this is a patient that I showed earlier. Ultimately, now if 1 year the patient had stable disease, but now ultimately you can see that the patient has now a shrunken, very cirrhotic-looking liver, has fluid around the liver, and ultimately has signs of portal hypertension. Unfortunately, 2 days ago, the patient actually succumbed to their disease, and I'm not really sure if it was due to tumor progression or if it was due to having underlying cirrhosis. So in conclusion, as I hope to have explained, neuroendocrine hepatic metastases treatment should be individually tailored. The goal is, again, for cytoreduction. Each therapeutic modality does have advantages and disadvantages, so I think that it would be very important for you to discuss this with your physician and to discuss it with your family to understand what treatment you actually would want. It takes a very high level of expertise to do these kinds of procedures, so I think it's important to also be in a very experienced center. And again, discuss the treatment options in detail with your family and physicians to see which is best for you. So with that, I will conclude, and thank you for your attention.